From Microbe TV, this is Infectious Disease Puscast, recorded on October 12th, 2023 at IDWeek 2023. I'm Daniel Griffin, and joining me today is a special guest here at IDWeek.
Hi, my name is Priya Kodiyanplakkal. I am coming from New York, from Weill Cornell, and thank you for having me today.
All right, so what brings you to Boston? What is going on? What is this whole IDWeek thing about?
So this IDWeek is the highlight of my year. It's a conference where we get to celebrate all the great work being done in infectious diseases. It's put on by the IDSA, the ID Society, and all the other societies together. And we get to celebrate all the research and hard work that's been done by the society. And I'm here to learn from all the experts about the newest in ID, and it's hard to keep up. There's so much happening these days that it's good to sit and get a refresher and a review of what's happened between last year and this year.
Okay, well, hopefully we can help with that educational effort, but Priya?
Okay, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting and entertaining. And during this episode, we'll also be talking about some highlights from IDWeek.
All right, and now on to the literature, shall we?
Yeah, let's start.
All right, I will start with the viral section. Don't forget to listen to This Week in Virology. But the first is a case report, survival from clinical rabies in young child from, how do I pronounce that?
Maharashtra, India?
Maharashtra, India, 2022, recently published in the American Journal of Tropical Medicine and Hygiene. So this is actually the case of a 3.5-year-old male child from Maharashtra, India, who presented with features of meningoencephalitis approximately 1 month after sustaining severe bite injuries on the right hand from a stray dog. He had received 4 doses of post-exposure intradermal rabies vaccine, days 0, 3, 7, and as they say, erroneously on day 20 instead of day 28 as recommended in the updated Thai Red Cross regimen, as well as local and systemic injections of equine rabies immune globulin. The child was initially diagnosed with and treated for acute encephalitis syndrome before rabies encephalitis was confirmed by detection of rabies virus neutralizing antibodies in the CSF. During the emergent period, he also received the anti-malarial drug artesunate, recently reported to have antiviral effects against rabies virus. With intensive and supportive care, the child showed substantial clinical improvement over the next few weeks. He has now survived for more than 10 months after disease onset, albeit with severe neurological sequelae, including diffuse cerebral and cerebellar atrophy.
But that's still a great outcome.
It's this would be number 2, right?
Yeah.
For people surviving rabies.
So.
And it's interesting because, the Milwaukee case was bat rabies. So some discussion about maybe, in other dog rabies, which is the main issue in India. But
it worked in this case. So I'm going to be talking about highlights from IDWeek during this episode. And the big talk in viruses this year is RSV vaccines. So compared to last year, October 2022, and this year, October 2023, we now have FDA-approved vaccines for RSV. So respiratory syncytial virus, or RSV, is an important cause of acute respiratory infection, lower respiratory tract disease, and death in older adults and young children. So like I said, this time last year, there were no approved vaccines, and now there are 2. There were 2 trials published in the New England Journal of Medicine, one in April of this year and one in September of this year. These were randomized control trials for RSV prefusion F protein vaccines, and one trial was done by Pfizer, the other by GSK. And these have now been FDA approved and are available now for people to get. So it's another plug as RSV season comes that people should consider getting the vaccine. There was also a trial done for pregnant women to look at the efficacy in them, and it's also recommended by the ACIP for pregnant women. And thinking about the other population at risk for RSV, which is young children and babies who are not eligible for vaccines because they won't mount a response, there is now a monoclonal antibody that was FDA approved also this year for, and we'll see if I say this right, but nirsevimab?
Nirsevimab,
Nirsevimab. Nirsevimab.
Or Beyfortus. There's a booth. I saw the booth down there with the special syringes.
And they had a special session on it during it. They were teaching about it.
Oh, fantastic.
So, but basically that is a monoclonal antibody for the prevention of RSV, lower respiratory tract disease, in neonates and infants born or entering their first RSV season. So we now have all these therapeutic preventative options that we didn't have a year ago, and that's really exciting.
Yeah, this is fantastic. On our clinical update, we actually talked about if an adult ends up in the hospital with RSV, they're more than twice as likely to end up on a ventilator or die compared to influenza, and even more likely to end up on a ventilator or die compared even to COVID now that we have background immunity. So RSV, big thing to focus on.
Yeah, and RSV season's coming up, so I think we're going to see more and more people getting it and more questions about it. I'm sure patients will be asking their clinicians what should they do and if they should get it or not.
All right, well, we'll keep circling back to that as we learn more, but in open forum infectious disease, the perils of overly sensitive viral load testing for persons living with HIV. Now, this has been, I think, a huge and important paradigm change. Well, in my career, I guess my career is kind of long, so getting old. But but this whole idea that if your HIV is well controlled, if your viral load is undetectable, that you actually cannot transmit it to another person, which really allows people to have that physical sexual intimacy. But when we say non-detectable, all those studies were looking at a viral load of 200 copies per milliliter.
Yeah.
But now we have these super sensitive tests. So a patient might see like, oh, it says detectable 40, am I really undetectable? And here's really a nice essay is really what it is, an opinion piece, really saying that there's actually demonstrable harms to reporting these really low viral loads as detectable and really getting people concerned, oh, now do I have to refrain from these behaviors? But just to remind our listeners, which this does, those studies used a viral load cutoff of 200 copies per milliliter. By undetectable, non-transmittable, it's 200.
Yeah. I think that's reassuring. I think especially these days, patients get their values on their phone sometimes before we even see them. And so to be able to reassure patients is a powerful thing with data behind it.
Yeah.
So I think the other big viral topic that's being discussed at IDWeek this year is cytomegalovirus, or CMV. As a transplant ID physician, I'm biased and think this is a very important topic, but I think overall it is a big development. There is a medication called letermovir, which was approved a couple of years ago for the treatment of CMV in bone marrow transplant patients to prevent CMV that happens after bone marrow transplantation. And so a randomized clinical trial, phase 3 trial, was done in kidney transplant recipients to see if letermovir would be non-inferior to the standard of care, which is valganciclovir, in preventing CMV infection in high-risk kidney transplant recipients. And what high-risk recipients are patients who have never seen CMV disease, but their donor organ comes from someone who's had CMV in the past. So they're at high risk of getting infection after transplant. And this phase 3 study that was published in JAMA earlier this year showed that letermovir was non-inferior to valganciclovir, looking at the primary outcome of CMV disease through week 52, so it's a long follow-up period. And it was non-inferior, but also it had less neutropenia and leukopenia in the letermovir arm. So non-inferior treatment and potentially better side effect profile. So that's exciting.
Yeah, no, I recently had a patient where we were discussing starting CMV treatment, and they looked through the side effect profile.
There's a lot of side effects to the current, medications we had traditionally, but letermovir is one of those medications that has a better side effect profile, and patients seem to tolerate really well and are less likely to discontinue it because of the side effects.
All right. Now this article I really like. Not that I don't really like the other ones, but I love history. I love when there's sort of these myths that are out there, and someone finally looks at it and you say, huh. So the article "Frailty and Survival in the 1918 Influenza Pandemic" recently published in PNAS. So one thing we've been told, right, about the 1918 influenza pandemic was that it primarily impacted young, otherwise completely healthy adults. And that was what made it so different, right? All these stories.
Yeah.
Well, here the investigators sought to ask whether the evidence actually support this. So they went ahead and they looked at skeletal remains from 369 individuals in a collection in Cleveland, Ohio. All right, I'm never going to Ohio where they just collect skeletons apparently. But they found evidence that people that suffered from chronic diseases or nutritional deficiencies were twice as likely to die as those without these conditions. So really sort of challenging this idea that it was just knocking down completely healthy people in their prime.
So it's probably people who are malnourished.
People who are malnourished, maybe they had some other chronic disease. So just sort of an interesting bit of science there.
Mm-hmm. And I'm sure we see this throughout time, that there are all these disease states that we didn't acknowledge back then that we acknowledge now. So
yeah, and people, they may not have even been diagnosed back then, right?
Exactly.
The person who says, "Oh, I'm completely healthy," well, then we find out at autopsy.
Yeah.
Nowadays, finally, we find out before autopsy. Hopefully, we can make a difference.
Exactly. So one paper I'm presenting is actually published today in the New England Journal of Medicine.
Oh my gosh, off the press.
It was on line a few weeks ago, but it's published today in New England Journal of Medicine, and it's SeptoBpro for the treatment of complicated Staph aureus bacteremia. So this is a phase 3 double-blind, double-dummy, non-inferiority trial in adults with complicated Staph aureus bacteremia. And they were assigned randomly 1-to-1 to receive either SeptoBpro, 500 milligrams IV every 6 hours for 8 days, and then every 8 hours after that, or daptomycin at a dose of 6 to 10 milligrams per kilogram. And the primary outcome was overall treatment success 70 days after randomization, and this was defined as survival, bacteremia clearance, symptom improvement, and no new Staph aureus bacteremia. And they could not have received any other effective antibiotics. The predetermined non-inferiority margin was 15%, and the outcomes were adjudicated by a data review committee whose members were unaware of the group assignments. Safety was also looked at, and in total, 390 patients were randomized. 387 had confirmed Staph aureus bacteremia, and they received either SeptoBpro or daptomycin. There were 189 in the SeptoBpro group and 198 in the daptomycin group. And a total of 132 of 189 patients in the SeptoBpro group and 136 out of 198 patients in the daptomycin group had overall treatment success. And the adjusted difference was 2% with a 95% confidence interval of -7 to 11, and that's within the predetermined non-inferiority margin. And so it was, similar across both groups, and even in the secondary outcomes, which is mortality, it was 9 versus 9.91% respectively. And the percentage of patients that had microbiologic eradication were 82% versus 77%, with a 95% confidence interval of -2.9 to 13. Adverse events were reported in 121 of 191 patients, or 63.4%, who received SeptoBpro, and in 117 out of 198 patients, or 59.1%, who received daptomycin. Serious adverse events were reported in 36 patients and 45 patients respectively, and gastrointestinal adverse events were more frequent with SeptoBpro. I do want to make a comment that not everyone actually had MRSA, which is where this would probably be of most benefit.
Yeah.
So But I still think this is a great option for MRSA bacteremia.
Okay, excellent. Well, we moved ourselves right into the bacterial section, and we have a few other ones here. Now, this is sort of interesting. This is an overlap. It's transition. It's viral and bacterial. The article, Adverse Pregnancy Outcomes Among HIV-Infected Women Taking Isoniazid Preventive Therapy During the First Trimester, recently published in CID. So this comes up, this sort of issue about you have a pregnant individual. What about isoniazid? Well, in this study, 128 participants had a known pregnancy outcome, 39 INH prevention treated, exposed, 89 unexposed. At pregnancy outcome, ART use was lower in the IPT exposed, 79%, than unexposed. First trimester IPT exposure was associated with, and this is nearly twofold increased risk of fetal demise, mostly spontaneous abortion, though the association was attenuated when adjusted for covariables proximal to pregnancy outcome, including ART use. So sort of raising concerns for using INH during that first trimester. All right, and the real-world application of oral therapy for infective endocarditis, a multi-center retrospective cohort study, was published in CID. So retrospective cohort study, keep that in mind, looking at adults with definitive or definite or possible infective endocarditis treated with IV only versus oral therapy at the 3 acute care public hospitals in this system between December 2018, June 2022. Primary outcome was clinical success at 90 days, defined as being alive or without recurrence of bacteremia or treatment-emergent infectious complications. So they go ahead, they identify 257 patients with endocarditis treated with IV only versus oral. So we've got 211 getting IV. We've got 46 of those folks getting oral transition. Study arms were similar for most of the demographics. There were a few little subtle differences. Now, there were no significant differences between the groups in clinical success at 90 days or last follow-up. There was no difference in recurrence of bacteremia or readmission rates. However, patients treated with oral therapy had fewer adverse events. Multivariable regression adjustments did not find significant associations between selected variables. But there's more. There's more. This is where it gets exciting. Linezolid was the most frequently used antibiotic despite its bacteriostatic mechanism.
And it still worked.
Yeah, so I think excellent outcomes with linezolid underscore the lack of clinical relevance of the static versus cytal paradigm, a myth debunked at a recent randomized trials and a 2018 systematic review.
Did they comment on if any of them had thrombocytopenia from the linezolid?
You know, I think that's one of the, I'm glad you bring that up, because that's one of the challenges with linezolid, but usually a challenge that we see after about 3 weeks of therapy.
Exactly.
So it sort of makes a nice oral transition, right? If you can treat for 4 weeks and you're not going to run into issues till after 3, usually you can get away with it.
You could get away with it.
Sure. And remember, we're now using linezolid for tuberculosis for pretty extended periods of time. So it's not like everyone at week 3 suddenly loses all their platelets.
No, this is true. Yeah. I think, you know, another thing that we talk about at IDWeek are developments for treatments for resistant gram-negative bacteria. So one paper I wanted to highlight that came out earlier this year was the ATTACK trial, which has a nice name. I like when trials have fancy names.
Sarah's a big fan. She rates them on a scale.
Yeah, I mean,
so
ATTACK is a really good name.
What do the letters stand for?
So the name of the trial is the efficacy and safety of sulbactam durlobactam versus colistin for the treatment of patients with serious infections caused by Acinetobacter baumannii calnocitius complex.
I like ATTACK. Let's just say ATTACK.
But basically, this is a multi-center, randomized, active, controlled phase 3 non-inferiority clinical trial. And it was an open-label RCT. They had a predetermined non-inferiority margin of 20%. They enrolled in 16 countries. They looked at adults with pneumonia, mostly hospital-acquired or ventilator-associated pneumonia. and they compared, they looked at how well sulbactam durlobactam did. They had 92 patients in the sulbactam durlobactam arm versus colistin arm had 89 patients. And both of these arms also had combination therapy with imipenem. So I think that's important. This is not monotherapy, this is a combination therapy. And the primary endpoint they looked at was 28-day mortality among patients with confirmed resistant Acinetobacter or CRAB.
I like that.
That's the acronym.
The ATTACK trial studying CRAB.
ATTACK's CRAB.
And when you mention CRAB, I always think of crabs, but CRAB, the other crab.
Yeah. And they showed that this was not inferior. And from the results of this trial, it was actually FDA approved in May of 2023 to treat CRAB. So again, big win, I think, a new treatment. And you can look at the results of the study in this paper in Lancet ID.
All right. So the paper, Information Delay of Significant Bloodstream Isolates and Patient Mortality, a retrospective analysis of 6,225 adult patients with bloodstream infections, published in CID. So this is that whole question, do we really need to be woken up in the middle of the night with those blood culture results? Well, interesting results here. The initial analysis, all microorganisms included, did not show an association of mortality and information delay to the odds ratio. However, information delays of bloodstream infections caused by fast-growing microorganisms, such as Enterobacterales, was associated with significant increase in the odds of death at 30 days, both in the univariate and multivariate analyses.
Which makes sense when we think of gram-negative infections being more aggressive.
So for all blood cultures that became positive during daytime working hours, which they define as 8 a.m. to 1:59 p.m., I don't know where they work. And then later, they talk about 8 a.m. to 7:59 p.m. That's good. The microorganism is identified and reported to the IDS immediately, typically within 1 hour. However, if blood cultures become positive during the, nighttime period, back in the old days, 2 p.m. to 7:59 a.m. Remember, that was the days of the giants.
Okay.
And then from 2013 to 2015, when the workday expanded from 8 p.m. to 7:59, transfer to the identification information is postponed until the next morning. So really what they're doing here is initially they're saying anything after 2 will tell you the next day. Later on, they're saying anything after 8 p.m. will tell you about the next day. So it's really interesting. I guess now when I get that late night call, I will just say, is it an Enterobacterales? And if they say no,
you can hang up and
I
go
can
back to bed.
hang right up and go back to bed.
Yeah.
All right.
Or tell them not to call you unless it's an Enterobacterales.
Yes.
That's even better. So
actually, do you think the new telehealth antimicrobial stewardship people that call me all the way through the night will read this study and only call me if they need to?
If you tell them about it, maybe. If they watch this episode, they will.
Okay, we will share this. Okay. All right, moving into fungal. Is there going to be another season of The Last of Us? I hope so.
We'll see. Fingers crossed.
Okay. All right.
Now that the strike is over, maybe.
Yes, actually, we'll have good writing. Otherwise, they were just going to do it with bad writing. All right. In critical care, we have critical appraisal beyond clinical guidelines for intra-abdominal candidiasis. Now, Sarah picked this paper.
Okay.
So for starters, I'm going to point out it's an opinion paper where apparently 12 authors actually agree.
That's impressive.
So isn't there some joke if you want 12 different opinions, you ask 12 different infectious disease physicians?
They must all be friends.
Yeah, and then they all talk about it for an hour. There even is one, who's going to jump in with no good answer here. And you're like, you can leave now. Here's a discussion of the alternative antifungal options for treating intra-abdominal candidiasis. So let's see what they have to say, what they agreed upon.
Yeah.
So they point out that echinocandins are recommended as first-line treatment. So they point out that echinocandins are recommended as first-line treatment in guidelines for invasive candidiasis. And here we read, however, considering published data, our pharmacodynamic analysis suggests the required increase of doses postulated by some authors to attain adequate pharmacokinetic levels in peritoneal fluid. Given the limited evidence in the literature on PKPD-based treatments of IAC, intra-abdominal candidiasis.
Obviously.
Anyone did,
Obviously.
I mean, I'm going to start throwing that out, IAC. An algorithm is proposed to guide antifungal treatment. Liposomal amphotericin B is advocated as first-line therapy in patients with sepsis, septic shock, presenting candidemia or endophthalmitis, or with prior exposure to chitocandids and or fluconazole, or with infections by Candida glabrata. They go on and have more to say. But why can't we all just agree? I often suggest that disagreement is usually a sign that we are in a data-free or a data-limited zone. The more passion and opprobrium, usually the less certainty. The authors rightfully conclude with the suggestion that there is a critical need for more robust clinical trials, studies examining patient heterogeneity, and surveillance of antifungal resistance to enhance patient care and optimize treatment outcomes. Such evidence will help refine the existing guidelines and contribute to a more personalized and effective approach to treating this serious medical condition. But then they go on. I thought that was such a nice conclusion.
Yeah.
But then they go on. Meanwhile, we have some ideas. It is suggested to broaden the consideration of other options, such as liposomal amphotericin B, as first-line treatment until the results of the fungogram are available.
I like that word.
And antifungal stewardship could be implemented to prevent the development of resistance.
I think that also probably should be tailored to your local epidemiology.
Your local fungogram?
Yeah, I think where in the world you are will determine if liposomal ampho B is a appropriate first-line treatment. I think, one of the themes we've seen during IDWeek is increased fungal resistance, and so this is becoming a bigger and bigger issue as time goes on. Speaking of IDWeek and things that are new from last year, and since this is a paper on candidiasis, I will mention that there was one trial for a new antifungal for candidiasis, rezafungin, which is a once-a-week treatment, a kind of candid. And so the results of that were published earlier. The trial is called Restore, but I know you guys discussed that on a previous Puscast, so people can tune into that if they want to learn more about it. What I wanted to talk about, I think, that was also mentioned during IDWeek here, I think medical tourism is becoming increasingly common, and with that is the risk of emerging or new infections that we do not commonly see here in the US. And in May of 2023, the CDC learned through the Emerging Infectious Disease Network that there were 2 patients in Texas who developed fungal meningitis after receiving procedures in Mexico, and they received epidural anesthesia, and they came back and had fungal meningitis. And since then, there's been published, update has been published in CID in last month, September of 2023, where this has now basically become a bigger outbreak. So a total of 185 residents in 22 U.S. states and jurisdictions have been identified who might be at risk of fungal meningitis because they received epidural anesthesia at the clinics of interest in 2023. Those 2 clinics were actually closed when this happened. And among these patients, 11 suspected, 10 probable, and 10 confirmed U.S. cases have been diagnosed with severe vascular complications and 8 deaths. The causative agent was determined to be Fusarium solani, which is a species complex, and it's been difficult to treat. And one of the isolates that was mentioned in this paper that was published it had poor in vitro activity for most of the available antifungals, which I think is why people are having poor outcomes. So currently, triple therapy with IV voriconazole, liposomal amphotericin B, and this is also new antifungal, fosmanogepix. I can't say that word.
See, if you say it, and then you'll be the one setting the pronunciation for the word.
No,
so go for it.
No, I am doing this wrong. Fosmanogepix. I usually wait for other people to be the first to say it and try to pronounce it, but I didn't have time before this.
Fosmanogepix.
Okay.
We're going to call it Fosmanogepix for all future.
I'm sure if you Google pronunciation, someone will say it the right way.
Okay. All right. And someone will say it the wrong way.
Okay.
All right. You know, I have to admit, like the first time I started reading about medical tourism, I was like, that's amazing that so many people want to travel and learn about all these diseases throughout the world.
No, that's not
yeah,
what that
apparently
is.
That's just me. Okay, moving.
You travel around the world to treat these infectious diseases.
All right. I thought that was medical tourism. All right. Parasitic. Be sure to listen to This Week in Parasitism.
Yes.
And actually, when this drops, it'll be right before we are doing a This Week in Parasitism at the American Society of Tropical Medicine annual meeting in Chicago.
That's exciting. Another live.
Another live one. Now, the very important article, Increasing Prevalence of Artemisinin-Resistant HRP2 Negative Malaria in Eritrea, was recently published in the New England Journal of Medicine. So really, what are the big things here? We are seeing not only that the malaria is becoming resistant to our medicines, but actually our rapid tests are missing the diagnosis.
It's concerning.
Very,
on
very
multiple
concerning.
levels.
Because in so many parts of the world, having a trained person to look at the microscope is not always an option. A lot of clinics are doing the rapid tests. That delayed treatment, particularly in vulnerable populations, young children, pregnant individuals, older folks. We were going to finish off with just a couple. I've got one. You've got one here in miscellaneous.
Oh, okay.
All right. And so the article, gender different. You don't have to do another if you're done. But anyway.
No, I can mention it. I don't have all the articles and data, but
all
I
right,
can
but
talk
that's
about
okay.
it.
So I am going to mention, and you can please weigh in on gender differences in psychosocial determinants of hand hygiene among physicians. So yes, published in Infection Control and Hospital Epidemiology. I'm looking at the crowd, and we're going to comment on what we know about your interest and reactions to hand washing. So these are results of a questionnaire survey conducted across 4 academic hospitals in Korea. So maybe this only applies to Koreans. They sent the survey to 994 physicians. Only 201 actually responded. All right.
I think that's typical survey response when you send it out to a large crowd.
Well, among then, 129, so 63.5% were men. Male physicians were identified 4 barriers as significant. These are barriers to washing your hands.
Wow,
Can you imagine that? I was going to wash my hands, but there are all these barriers. One is time wasted. All that time I could be doing something else instead of washing my hands. Washing my hands is just not really a habit. That's sort of interesting. Forgetting about hand washing. No real disadvantage to me if I don't wash my hands. Now, what about female physicians? They identified pain and dryness of the hands as a significant obstacle.
Because they're actually washing their hands.
They're actually washing their hands. And men like, my hands don't get that dry. Sometimes I think my teenage son is transporting soap to the drain. I'm not sure there's really any washing going on. My oldest daughter is now certified as a nurse who can wash her hands, or certified nursing student. Anyway, the other, and I thought this was really interesting, is the female physicians had a higher tendency to feel uncomfortable when a fellow employee performed inadequate hand hygiene.
Because they see their male colleagues.
They see their male just doing that, just transporting, and they're just like, oh my gosh. And we're just like, oh, that's what I do. Because I don't want to waste all that time. Could be doing something else important. Among the respondents, 26.6 identified diversifying the types of hand sanitizers as their first choice. So if we have options, maybe different bottles, different smells, followed by providing reminders. Someone saying, Dr. Griffin, please wash your hands. Because we forgot. We're like, oh my gosh, I forgot him. So let's do that every single time. And having soap and paper towels in each hospital room.
I think the having soap in each room or a sink sometimes even, is hard to find. Sometimes I put soap in and then I realize there's no sink, it's out in the hallway.
Sometimes I put the soap on, I think it's the alcohol, and now I'm like, oh my gosh, I've got soap, where's the water? And I'm wandering around the hospital with soapy hands.
No, but I think
But not very often, right? Because I'm busy doing other stuff.
Or you don't remember.
Not wasting all my time on hand washing.
No, I think we all know that we all need reminders, and that when you don't remind healthcare workers, it drops off, but then it picks up, and education is important.
See, as a good Irishman, when they switched over to the alcohol base, and I read the study that you can actually generate an identifiable alcohol level in your blood by doing enough of that alcohol hand sanitizer, that's constant
that incentivized
positive feedback for me. Yeah.
No, but I think,
According to our audience in Scotland, they drink it.
Yeah. No, I think
the alcohol or the hand sanitizer. We're not sure.
Both.
alcohol too.
Yeah.
Okay.
I'm surprised though. I would think with COVID, when was this before or after COVID? I would think with COVID, people are more cognizant of washing their hands, but it could be, everyone has short-term memory. But
What did you say? Something? No. Okay.
no, but I think we all agree hand washing is important,
Yes.
and I'm sure Shay would want us to say that too.
Yes. Yes.
Healthcare workers should wash their hands.
Yes. Yes.
Since
This
we're
is
at IDWeek.
This is a Shea approved message.
Yeah, wash your hands. It's important.
And the xenotransplantation, there's something
yes.
exciting there.
Yeah, so I think, I am a transplant infectious disease doctor who works, who is excited by things like this. So I think a new development that we're all seeing in the news is xenotransplantation. So it's coming, which is xenotransplantation is transplantation of organs from pigs, in this case, into humans. And the trials that have been done is to look at, is this feasible, is this possible? And it seems like it is. And I think that will open up a whole new world for ID physicians. So I recommend, there is one great review article that was in New England Journal done by Jay Fishman, who's here in Boston.
Okay.
He did a review article in the New England Journal talking about what ID doctors need to know about xenotransplantation and the possible things that we'll need to look out for. So things like infections from the graft, the immunosuppression from our patients. I think this is going to be a whole new world that we'll have to learn more about.
Okay, fantastic. All right,
and with that, this brings us to the end of this Puscast from IDWeek in Boston. As always, the references for all the articles mentioned on the show are available at Microbe TV, the home of this multimedia empire.
And you can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We'd love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. Any of the hate mail about the Scottish, that was Michael Schmidt. So that'll be a twin. If you like what we do, consider supporting the science shows of Microbe TV at www.microbe.tv/contribute, or go to Parasites Without Borders. It's easier. Just go to Parasites Without Borders and just click right on that donate button.
Nice button there. So I'm Priya Kodiyanplakkal. You can find me on X at RK3 or at Weill Cornell Medicine. I'm a physician there.
All right. I'm Daniel Griffin, and you can find me at CUIMC, Columbia University Irving Medical Center, or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. Puscast will be back in 2 weeks, and another Puscast is infectious.